Hi, my name's Sandeep. I'm one of the clinical fellows at Wythenshawe Hospital, and I'm going to talk to you about how to review a patient who's fallen. So, why is it important that we talk about falls? Well, falls are a common reason for you to be asked to review a patient on a care of the elderly ward. Amongst other things, it can lead to an increased rate of mortality. You might have heard of the falls team in your local hospital. The falls team carry out a root cause analysis to find out why patients have fallen and what was being done previously to prevent them from falling. They come up with new ways that they could reduce the number of falls on each ward. Probably not these days, but a few years ago, patients were being labelled as off legs or having acopia, and this could have meant that they were more at risk of having falls or had previously fallen. It's important that we identify the cause of why the patient has fallen when we review them, and also understand that often the cause is multifactorial. It's important to appreciate how the patient was doing prior to their fall to work out if they have acutely decompensated from either an acute or chronic condition. And finally, it's important to appreciate the damage that's happened as a result of the fall. So you've been asked to come to a ward to review a fall. Nursing staff have called you. What should you ask the nursing staff? Well, firstly, you should ask them, has this fall been a witnessed fall or an unwitnessed fall? Has anyone seen it happen? Perhaps another member of staff or another patient. Maybe it was a family member. And then what happened? Go through the sequence of events. How long has the patient been on the floor? Is this someone who was last seen on an OBS round 4 hours ago? Or is this someone who was up and about 20 minutes ago? How did the patient seem earlier in the day? Were they confused? Were they unwell? Or were they seemingly fine? Is the patient currently alert? Has the nurse been to see them? Is there any obvious sign of injury? Do they have any laceration or trauma to the head? Are they clutching their chest? Does their leg look externally rotated or shortened? Next, what should you ask the nursing staff to do? First, you need to ask them to do a set of OBS, including neuro observations. These are usually done hourly, but it depends on your local trust. Following this, it's important to get a random blood glucose as closest to the time that they've fallen. And finally, a lying and standing blood pressure if they're feeling well enough to have it done at the time. If not, it can be done later. So you've come to your patient and you're ready to assess them. So we're going to go through an A to E assessment and the things that you might pick up on the assessment that might be relevant to why the patient has fallen. So first, A, assess the airway for any obstruction. Is there anything that could have caused them to become hypoxic and then fallen? Have they choked on any food? Is there anything obstructing their airway? B, breathing. Having a listen to their chest, are there any crackles? Could this indicate that they've developed a pneumonia or have heart failure perhaps? Do they have a background of pulmonary fibrosis? Is there a wheeze? Is the patient known to have COPD or asthma? Could this be an exacerbation of their underlying condition? Or perhaps their heart failure is producing a cardiac wheeze? Listen out for reduced air entry. If it's in the apices, could this be a pneumothorax? Or if it's in the bases, could this patient have a pleural effusion? Tachypnea. PE can often present as collapse, and it's important to remember that if a patient sat in front of you with a higher rest rate. And finally, silent chest, particularly if they're asthmatic, this would be of great concern. So this image here shows quite nicely a CT scan, a CTPA of a patient's chest with a saddle thrombus across the middle. And it's important that we get used to looking at CT scans before the radiologist report them so that we can gain some experience looking at them. Finally, moving on, C for circulation. Does the patient have a raised JVP? This is a good example of a raised JVP on a patient. This would be, again, in keeping with heart failure. Next, you want to have a look for signs of dehydration. Do they have dry mucous membranes when they stick their tongue out? Could this patient be hypotensive? Do they have an irregular pulse in keeping with atrial fibrillation, or perhaps a thready pulse? Tachycardia? Are they perhaps hypotensive on their observations? All of this would be in keeping with signs of shock. Tachycardia can be seen in PE too. Does the patient have a murmur? Is this a new murmur or is this a known murmur? If it's new, it could be infective endocarditis that's caused them to become septic. If it's an old murmur, perhaps their aortic stenosis or mitral regurg has gotten worse and has decompensated. Does the patient have cold peripheries, a CAP refill time more than 2 seconds, or poor urine output? Again, this is all in keeping with shock, particularly if they've got poor urine output. Think about AKI, and if they have AKI, this can lead to conditions like long QT, which can again cause collapse. Is a patient obviously bleeding from anywhere? Do they have a PR bleed or have they had some trauma? D for disability. It's important to check their blood glucose, which I mentioned earlier. We'll talk about hypoglycemia. Particularly if your patient is diabetic, on insulin, have they been eating during the day? Have they been unwell? Have they had any concurrent illnesses? Perhaps they've been vomiting or they've been nil by mouth before a procedure and they've had too high a dose of insulin and that needs reviewing. But if they're not diabetic and their blood glucose is low, then we have to think about Addison's. And then it's important to check their cortisol levels and their sodium and potassium and their blood pressure. Sometimes collapse can be an initial presentation of Addison's. But also, if it's hyperglycemia that the patient has, this patient may be presenting with DKA. In that case, it's important to check their ketones either within their blood or their urine. Get a general assessment for the patient's alertness. So is the patient responding to you normally? Are they only responding to voice? Or is it pain that makes them respond? Perhaps the patient's unresponsive. A more detailed version of this is the GCS. Appreciate their limb movements, their eye movements, and their voice. Neuro-obs. This is something you would have asked the nursing staff to do initially when they called you. Neuro-obs are a collection of the GCS, pupillary reaction, and power. And I'll show you a chart in a little while. E, exposure and everything else. Check the patient's temperature. If the patient's febrile, this could be in keeping with sepsis or an underlying infection. Check for injury. If they've said that they've landed on their wrist, check the state of their wrist. Is there any swelling? Look at their limbs. Are they rotated, shortened? Is there any evidence of trauma to the head? Any lacerations? Any bruising? Any bleeding? Look for broken joints. So ask about pain and range of movements, particularly if limbs look shortened, externally rotated, swollen, bruised. Check the range of movement in these joints. So this is an obvious neck of femur fracture here on an X-ray of somebody's hip. But this one is perhaps a little more subtle, and it's important to have a good look at these X-rays after you've ordered them for a patient who's got pain in their leg or their hip after having a fall. So this is what the neurological observations chart can look like. So up here we've got the patient's GCS, and they get a score for each section. And then here the patient's power is recorded, and then the pupillary reaction, both the size and the reaction to light. Next, let's talk about the history. What sort of questions do we need to be asking to work out why the patient has fallen? Well, first, is there a collateral history available? Has somebody seen this patient falling, particularly if they're confused or if they have a background of cognitive impairment? Next, we need to establish their baseline. Are they chronically confused, or if they're acutely confused? Is this delirium? Review their medications. There's lots of medications that can cause various symptoms that predispose patients to falling. So patients could be on a number of medications that cause confusion, for example, opioids, benzodiazepines, antimuscarinics, and TCAs. Patients can be on medications that cause low sodium hyponatremia, particularly PPIs like lansoprazole or omeprazole. They can be on antidepressants like SSRIs, ACE inhibitors, and diuretics that can cause low sodium, and this can predispose them to falling. Does the patient have any medications that would predispose them to postural hypertension? Any antihypertensives, for example? Or has the patient been recently started on steroids that can predispose to psychosis? If a patient's able to answer the questions, next we need to work out what happened right before they fell. Were they feeling well during the day? Or were they feeling unwell with another concurrent illness? Right before they fell, did they have any chest pain? This might be in keeping with myocardial infarction. Before they fell, was there any unilateral weakness? Perhaps they noticed their speech was a bit slurred, or part of their vision was missing. Did they have a stroke that led them to fall? Did they have any pre-syncopal symptoms like nausea or feeling faint? Perhaps they were feeling a bit sweaty beforehand. Could this be a vasovagal episode? Were there any palpitations? Perhaps shortness of breath? Could this be a valvular problem that's caused them to collapse? Was there any dizziness? Did they suffer from vertigo? Was there a bout of vertigo before they fell? Next, you want to establish what was happening during the fall. Firstly, do they remember the fall? Was there any loss of consciousness or any amnesia before or after they fell? During the fall, did they notice that they bit their tongue or that they had a bout of incontinence? And then post-fall, after falling, have they noticed that they've had any new neurology? Is there any new weakness, new sensory loss? Perhaps they've now got a deficit in their vision or slurred speech. Has the fall caused them to have some sort of trauma to their head? You want to ask them about the site of impact. So do they have any pain anywhere? Perhaps they landed on an outstretched arm or they landed on their hip. Ask them if they have a headache. Did they develop a headache despite no head injury? Could this be a subdural hematoma in the absence of head trauma? And also ask them how they felt after they fell. Did they feel that they got better straight away, or was there a post-ictal period? Finally, how long did they remain on the floor? Were they there for an hour? Were they there for many hours? Could they be at risk of rhabdomyolysis and subsequent AKI? Next, let's go through some of the investigations that we should order for patients that have fallen and what they might show. Well, we may choose to do a set of bloods. A VBG, for example, might show a raised lactate. And in the case of a patient falling, if it's considerably raised, for example, more than 5, it might be in keeping with a seizure. But a raised lactate can also indicate a patient having sepsis. If there's an indication to do an arterial blood gas, respiratory alkalosis or hypocapnia will be in keeping with a patient who has a PE. Respiratory acidosis might be seen in a patient who's got an infective exacerbation of COPD. Then the blood tests. You want to make sure that you're doing a full blood count and CRP, particularly because this will give us an indication, again, about sepsis and an infection. The hemoglobin might turn out to be low. They might be having an upper GI bleed that's going amiss. Perhaps a low hematocrit, again, in keeping with heart failure. Their sodium and potassium might be low. Now, we spoke about Addison's earlier. It could be that they've got a low sodium and a high potassium, but if they're on diuretics, this might be leading to them being dehydrated, or a low sodium might be in keeping with SIAD. It's important to check their troponin, particularly if they've complained of chest pain prior to the fall or any nausea or sweating. This might indicate that they've had a myocardial infarction. Next, we move on from the bloods to imaging. Chest X-ray is usually a basic form of imaging for most patients that have fallen. Particularly if they have neck or femur fractures, it's important to order a chest X-ray to find out if there's any underlying lung condition. One of the things that we're looking for on those chest X-rays is consolidation. Having a lower respiratory tract infection or pneumonia or a mass can put you at risk of falling. Perhaps they've fallen and now they have rib fractures. Again, that's something that would be visible on a chest X-ray. If they've got dullness to percuss or reduced breath sounds at the bases, they may have pleural effusions on the chest X-ray that would be, again, in keeping with heart failure. You want to have a look at an ECG. ECGs in these cases might be abnormal. They might show bradycardia. They might show second-degree AV node block, for example, Mobitz type 2, Trifacicular block, or MI, all of which can cause you to collapse. If it's warranted, particularly in an elderly patient on anticoagulation who's had a head injury, you might need to do a CT head. CT head might show a subdural hematoma, particularly obvious on this CT head up here. The patient may have had a hemorrhagic stroke, which has caused them to fall, or perhaps a subarachnoid hemorrhage, which has caused them to fall, as you can see on this CT head here, where there's blood in the sulci. Or perhaps the CT head might show an early infarct, but an MRI might be needed later down the line to establish this. If they have any obvious pain in their hip, it would be appropriate to order an X-ray of their hip to check if they have a neck or femur fracture. Let's talk briefly about heart block. There's various types of heart block, but I'm going to talk about 3 different types. So first, we've got complete trifascicular block. This is right bundle branch block with left axis or right axis deviation and 3rd degree heart block. So this is complete trifascicular block. Then we've also got incomplete trifascicular block. This can be right bundle branch block with left axis deviation or right axis deviation and either 1st or 2nd degree heart block. This is important because incomplete trifascicular block can progress to complete heart block, and both are indications for needing a pacemaker, particularly if there's Mobitz type 2 on the incomplete trifascicular block, as you can see here. Bifascicular block is when you have right bundle branch block and axis deviation. So this image here is an example of complete trifascicular block. So we've got right bundle branch block, we've got left axis deviation, so lead 1 points upwards, lead 2, 3, and AVF all have complexes that point downwards. That's an easy way to remember it. And it also has this 3rd degree heart block where the P waves don't really correlate with the QRS complexes. Syncope. There's various different types of syncope. Sometimes syncope is used to refer to vasovagal episodes. So this is when a predisposing factor, for example, fear, stress, pain, or prolonged standing causes a patient to have initially pre-syncopal symptoms, feeling faint, nausea, sweating. And then this can lead to a few seconds of loss of consciousness if the patient doesn't sit down or lie down. This can be accompanied sometimes with postural drop. Sometimes people talk about cardiac syncope or cardiac causes of patients collapsing. These are usually a sudden onset of collapse followed by a sudden recovery. The patient might have cardiovascular symptoms like shortness of breath and palpitations. They might be quite nauseated or sweaty. Next, we've got neurological syncope or neurological collapse. With this, it's usually associated with either headache or focal neurology and perhaps reduced GCS. And sometimes patients have seizure. Seizure is usually associated with aura and a post-ictal period following the collapse. The lactate's usually high. Sometimes they have incontinence and tongue biting. And an examination, by the time you've got there, they're usually quite drowsy in that post-ictal period. There's also something called situational syncope. There are certain situations where patients can collapse. First, micturition syncope. This usually occurs in middle-aged men that stand up to urinate. Essentially, the treatment is to ask them to sit down. Carotid sensitivity is a phenomenon that involves carotid massage, essentially, and that can occur from shaving. And cough syncope as a result of having a coughing fit. So it's important to understand what the patient was doing prior to their collapse. Next, let's talk about this term, mechanical fall. It's a bit of a lazy term that doesn't really appreciate the multifactorial nature of patients falling. So we'll talk about some of the causes why patients might fall and what this term can sometimes encompass. So firstly, check their sight. Does a patient normally wear glasses? Have they forgotten their glasses at home? Or perhaps have they recently been started or prescribed new glasses, in particular bifocal or varifocal lenses that can cause them to be quite dizzy and fall? Is this patient's environment unfamiliar to them? Hospitals at nighttime can be quite scary places. They are dim lit. Perhaps the patient's been moved from a different ward and they thought that the bathroom was closer than it was. Does the patient have any problems with their mobility or balance? Do they have something, for example, wrong with their cerebellum or their inner ear? Do they have undiagnosed Parkinson's? Is the patient confused? Confusion can often cause patients to fall. Is this confusion acute? Are they delirious? Or do they have a chronic cognitive impairment like dementia? If the patient's delirious, it's important to appreciate this with a 4AT assessment, but also to establish the cause of their delirium, because most of the time it's reversible. It's important to ask them about their bowel habit. Are they constipated? Are they on any medication that might be causing them to be confused? Or perhaps they've got an underlying infection. Does a patient suffer from peripheral neuropathy? There's lots of reasons why a patient might have this. Perhaps their B12 is low, they're alcoholic. Are they diabetic? Has this been diagnosed? Has it been adequately treated? Do they have any underlying conditions that are poorly managed? For example, Parkinson's or arthritis? Do they need better pain management? Elderly patients can often have reduced muscle tone. One of the reasons for this can be low vitamin D, so it's important to check their vitamin D levels, particularly if they're at risk of falling. Is a patient falling on the way to the toilet? Are they having to urinate often? Do they have urge incontinence? Or are they taking diuretics? Are they having lots of caffeine? Do they have an increased alcohol intake? And we've spoken about medications that can cause confusion, but also medications that can cause low blood pressure. Check their footwear. Are these the patient's normal shoes? Are the shoes too big for them? Are they too small? Are they wearing shoes? Are they walking around in their socks? So why is it important to prevent further falls? Well, I spoke briefly about mortality being increased earlier. Mortality is from head and hip injuries. From neck and femur fractures, the mortality rate is very high at 1 year. At 1 month, the mortality rate is about 10%, but at 1 year, this increases to 33%. That's a third of all patients that break their hip. So that's hip injuries, but what about head injuries? Let's talk about subdural hematomas. It's important to appreciate that they can actually occur in the absence of a head injury. They usually present with a change in the GCS or a headache, perhaps neurological deficit, but sometimes they can happen and cause only a mild symptom, like, for example, a bit of deafness. So the reason they occur is because with age, patients' brains undergo cerebral atrophy. So the brain shrinks, which then pulls on these bridging veins that connect the skull to the brain. When these are taut already, any sort of impact, even from falling without a head injury, can cause these to tear and cause a bleed. This is usually seen on a CT head, particularly if patients are on anticoagulation and they have any change in their neuroobs. But sometimes the CT head comes back as normal. If you have a normal CT head and you have a patient whose neuroobs are deteriorating, consider repeating the CT head. It might just be too early to appreciate the changes. If a patient has a subdural hematoma on a CT, it's important to discuss it with neurosurgery. Often in this elderly population, they will advise that we monitor the neuroobs and repeat the CT head in a few days to make sure that the bleed isn't increasing in size. Although not practiced these days, it used to be more acceptable to stop patients' anticoagulation if it was felt that they had an increased risk of head injury from falls. But actually, the evidence shows that a patient with atrial fibrillation would have to fall more than 300 times a year, which is almost every day, in order for the risk of intracranial hemorrhage to be higher than the benefits of anticoagulating to prevent a stroke. Postural hypertension. How do we measure a lying and standing blood pressure? So, this is the procedure from the Royal College of Physicians. First, take a manual sphygmometer if possible, but if not, one on the wards, making sure that it's the correct cuff size for the patient. If the cuff is too small, the blood pressure might be falsely high. If the cuff is too big, the blood pressure might be falsely low. Lie the patient down for 5 minutes and take the first blood pressure. Then ask them to stand up, taking the second blood pressure at the first minute and the third blood pressure at the third minute. If your patient has a drop in the systolic blood pressure of more than 20, or if the systolic is less than 90 on standing, then you have a positive result. If the diastolic drops by more than 10 millimoles of mercury and the patient has symptoms, then you also have a positive result. Talking about postural hypertension, it's important to treat the underlying cause first. So often this can mean stopping the antihypertensives. Patients can be overtreated for hypertension in this age group, particularly if they're at risk of falls. It's important to have a look and see whether those medications are warranted. The other sort of causes that you need to look out for are peripheral neuropathy, optimize their diabetic or their glycemic control, check their B12, and perhaps check their other medications like Parkinson's medications. Alongside Parkinson's disease can both cause patients to have hypotension. In terms of managing postural hypertension, once you've tried to treat the underlying cause, the first thing would be non-pharmacological methods. So compression stockings or an abdominal binder. Speak to your orthotics team to see if these are available within your trust. If this doesn't work or they're not available, the pharmacological options are usually fludrocortisone followed by midodrine. Both of these can cause patients to have fluid retention and hypertension. Thank you for listening to this talk. Please fill out the feedback form via the link below. Thank you.